Good afternoon to everybody, and thank you very much to Manos and Manos for this invitation to this outstanding meeting. I'm really very happy to be here in Athens. So let's talk about the complication of Latarjet. Unfortunately, despite the excellent results, the Latarjet procedure has a complication rate, as you can see here, between 15 and 30%. And if you look at these lists, effectively, we have a lot of complication after this successful surgical procedure. We can have early postoperative complication and long-term complication. These are the early ones. The first one is about the graft malpositioning. Sometimes we can position the graft too high and we have a recurrent instability because we don't correct the glenoid tract anteroinferiorly in this case, or otherwise we can damage the suprascapular nerve with the screws because we drive the screws in the upper position and we can damage the nerve. Otherwise, sometimes we can position the graft too low, and in this case we have an insufficient fixation of the inferior screw. This causes a single superior screw rotation, as you can see here, with a weak biomechanical construct that causes a fibrous non-union. Sometimes it's too medial, and in this case we have no increase of the glenoid tract with a consequent recurrent instability, of course. And the last, but not the least, of course, complication of graft malpositioning is the position to lateral with a lateral overhang that causes a secondary osteoarthritis. Sometimes we can have a graft fracture, as you can see here, and the most of the time is due to an overtensioning where we drive the screw inside the coracoid, and sometimes we have to follow the suggestion of our master that suggests us to drive with 2 fingers the screws inside the coracoid. Other time is caused by an excessive decortication of the undersurface of the coracoid. Keep attention to the size of the drill, keep attention to the size of the screw, and please take always the safe distance. The safe distance is the distance between the implant and the coracoid osteotomy that must be at least equal to the diameter of the implant. Sometimes we can have a screw malpositioning, of course. Please respect the alpha angle. What is the alpha angle? The angle is the angle between the glenoid rim and the final position of the screw. Increasing the alpha angle more than 30 degrees may lead to displacement of the graft. The screws must be parallel to the glenoid articular surface in order to improve bone union of the graft to the glenoid and reduce the likelihood of lateral positioning of the graft, as you can see here. Screws should be placed as parallel as achievable in order to optimize the compression and avoid fracture of the bone graft. Nerve injuries are really a very scary complication of this surgical procedure, unfortunately. Rudelani in 2014 published this interesting paper monitoring patients during 34 Latarjet procedures. The most common stages of this procedure was for a nerve alert, where glenoid exposure and graft insertion. 35 alerts for axillary nerve and 22 for musculocutaneous nerve. You can see now an interesting specimen from Giovanni Giacomo that shows the proximity of the nerves in the operating area. Really, really very close. So keep attention when we perform this kind of procedure. But don't forget the back of the scapula, because we have the suprascapular nerve, and we have to pay attention to the length of the screw and the orientation of the screws, because sometimes we can damage these nerve branches. Instead, these are the long-term complications. The first one maybe is the graft reabsorption that is really very common when we observe a long-term X-ray follow-up of Latarjet. What is the graft reabsorption? We have to keep in mind that the coracoid graft region is most involved in osteolysis is the proximal and superficial zone. Why? Because the distal region of the coracoid bone graft, especially in the deep portion, is the one less involved in osteolysis and with the best bone healing because it is close to the conjoint tendon. So, we are talking about absorption or remodeling? Keep in mind that this process occurs at 360 degrees, affecting not just the upper portion, but also the lateral part. Look at these images. And remodeling is a result of bone stimulation according to the Wolff's law. Sometimes we can observe screws breakage, less than 5%, and instability recurrence. We have talked about that since now we will talk more after me. And unfortunately, even this very successful procedure has this kind of problem, as you can see here. So if you didn't have done any mistakes during the surgical procedure, look at the negative prognostic factors, particularly for the MDI. There is one prognostic factors for this kind of procedure that we have to avoid. And what about epilepsy? In literature, we have found no differences between epileptic and non-epileptic patients. The risk of recurrence after Latarjet was related to the severity of bony lesions found in this population instead of the neurologic condition itself. Sometimes we can observe a loss of active internal and external rotation. The most of the time is due to the vertical split of subscapularis instead of the horizontal split. And what about the osteoarthritis? As you can see here in this review, the radiological signs of shoulder osteoarthritis are found in 25%, but only the 6% is affected by second and third degrees. Despite that, good and excellent functional outcomes with a generally high patient satisfaction, over 90%, and great rate of return to sport upon the injury level in athletes are observed after this surgical procedure. At the increase of the follow-up, you can look to the increase of osteoarthritis, as you can see here in this level. And however, we have to observe that osteoarthritis is a common complication also after anatomic shoulder stabilization procedure like Bankart repair. Maybe because of the increase of the contact pressure between the humeral head and glenoid surface. First factor, anyway, is the overhanging position of the bone graft. And what if we have a young patient that exhibits advanced shoulder osteoarthritis? What can we do now? Drugs, physical therapy, injection, hyaluronic acid, stem cells, but at the end, maybe we have to perform a shoulder arthroplasty. And what are the outcomes? Surely we have improvements in pain relief and function. What about the total shoulder arthroplasty? We will get the best range of motion, or we can get more complications like anterior shoulder instability if we don't have the competent subscapularis, or risk of glenoid component loosening. And what about RSA? Surely it's more stable, but we have a lower satisfaction rate in the people that we have to operate because they are usually young. And we have a big reduction on the range of motion. So it's a challenging procedure. What do we do? Do we have other alternatives? Maybe the glenoid soft tissue resurfacing? Unfortunately, at the beginning it's okay because we preserve the bone stock, of course, but in the end, unfortunately, fail. You can see here a clinical failure rate more than 50%. So maybe the new way can be the pyrocarbon head that allows a high performance demand and longevity on the implant and lower revision rate, as you can see here. Now this is my way to address this kind of pathology when I can. Thank you.